you. Okay. So, we're done with chapter 23, so now chapter 36. This chapter goes over all of the different GI disorders, the most common GI disorders that are out. Now, the beginning of this chapter goes over just like basic terminology, which is on, some of the terms are on the medical term list that is posted on e-college. So we will go through some of the terms and then get right into the diseases. Okay. This chapter is a little more interesting. I find it fun going over GI disorders. So we'll be talking about belching and all kinds of good stuff like that. So, now the first, I should say term word, medical terminology word here is dysphagia. Dysphagia is difficulty in swallowing. Okay, difficulty in swallowing. Now you remember from anatomy, you guys learned the terms mastication and deglutition. Mastication, as you know, is chewing. Deglutition is the act of swallowing. So with dysphagia, remember that deglutition, if you remember from anatomy, was in 3 phases. Okay, and so what happens here is dysphagia is in 3 phases or 3 types. Okay, so depending on what area and what's going on. So dysphagia, difficulty in swallowing, so the inability to initiate swallowing. What happens here, this can be liquids or solids that can get stuck, okay? And they do have the sensation that something's stuck in your throat, and if you've ever experienced that, okay, you know what that feels like, okay? Accompanied with omniophagia, okay, which is pain, okay, pain upon swallowing, or when swallowing. That picture's in the wrong spot. We're not at the colon yet, we're still in the mouth. Okay. So, type 1 is a problem with the delivery of food, okay, getting into the esophagus. So you know that the first part of deglutition is in the oropharynx and how that food gets to the esophagus, okay? So what happens here is that this can be a situation where a person cannot coordinate, and when they begin to swallow, coordinate that movement. So you know the first part of deglutition is voluntarily controlled. So we have to initiate swallowing and bring the food back to the area. Now, the rest of it, once the food gets to the esophagus and all the way down, that's involuntarily controlled because gravity takes place, okay? But then there's other things that can cause it to get stuck. So with this type of dysphagia, type 1, this is when this person has some sort of neuromuscular condition that doesn't allow them to swallow the way they should. Symptoms can be coughing, or they can expel food or fluids through their mouth or their nose because it has to get out. It's not going down the right way, so it has to come out, so it cannot have a constriction or an obstruction. So, and it can come through the nose. Some people do this on purpose, try to make stuff come out of their nose. But these individuals, they have to cough it up, and sometimes it can come either out the mouth or the nose. Now they say it's worse with liquids than solids because solids are easier to contain. Liquids can go anywhere, and it's harder to contain a liquid, okay, especially in this situation. Type 2 is when they have a problem transporting the bolus down the esophagus. So you know what happens when you have the esophagus will go through its segmentation type of situation and move the bolus and everything down. And so what will happen here is that when they're trying to move this down, it's not moving down as it should. Couple of causes. One cause can be something called a diverticulum. What is that? I don't know if you guys have heard of this before, but this is now what we call an outpouching that can happen in the GI wall. So for some reason, let me just draw on the board. So some reason the GI wall here can now get a little lax where it will now cause a sort of outpouching, okay? And then what will happen here is that when you eat and you start to swallow food, and the food will just get kind of trapped in there, okay? So that can be a problem. Another problem too can be if the smooth muscle itself is not moving, pushing the food down as it should, or sometimes if there's some sort of obstruction, like if a person has a cancerous tumor or whatever type of cyst or whatever that could be there. Okay. Now, With the symptoms of type 2, they will feel like something is stuck behind their sternum. Okay, so right here they'll have a pain. So not all the way up here because it's a different location. We're now in the area of the esophagus. Okay. Type 3, this is when they have a problem with the bolus entering into the stomach. So this is usually caused by the lower esophageal sphincter not opening all the way to get the food through. So this is different from GERD, not GERD yet, okay, but this is where this person has food and the food is trying to get into the stomach, but the lower esophageal sphincter is not opening enough to get that food to go through, okay. So what will happen here is that they will have chest tightness and substernal pain as they're trying to swallow. So they will have pain in this region, okay. Kind of like a heartburn feeling, but not a burning sensation, but a pain sensation in that region. Okay, this picture, don't worry about that, because we'll go over each and every one of those. Now, we do have a couple of more pains and things to talk about here. So, esophageal pain. Under esophageal pain, we do have something called pyrosis, which is heartburn. Okay, so we already know what is the major cause of heartburn. You guys already know this. What causes heartburn? Very good, acid. So we're talking about highly acidic. Keep in mind that the stomach is very, very acidic. It's actually at a pH of 2, if I can remember, 1 or 2. And keep in mind that that acidity for the stomach is there for what reason? To break down food, and there's another reason. Very good, to kill bacteria. Okay, so your stomach has to be acidic. The problem here is that the esophagus doesn't need that acidity. So the way the epithelium is laid out in the esophagus, it's not equipped to handle that type of acid. So what will happen here is that when you have this sort of acid reflux, the acid splashes back up into the esophagus, causing this burning sensation, okay, because it actually starts to affect the epithelial wall. Okay. So symptoms, burning sensation, it may radiate up into the neck or the throat region. Okay, if you've ever had a heartburn feeling, you know what that feels like. Okay, now, chest pain. We talked about this before, and I told you that sometimes people can have chest pain or what you call angina, and it can be from anything. And GI is one of those conditions that can give chest pain, okay? And not to say that it can mimic a heart attack, but if a person has angina, you don't know, okay, what it is until you figure out some other signs and symptoms. So with this, sometimes a patient can have maybe something obstructing the esophagus, okay, where it can give them a chest pain and radiate to the arm or the neck and mimic an MI, okay. So this can definitely happen. Abdominal pain. A lot of things can give abdominal pain, but they break this down into 3 different types of categories here. So first thing we have is what is called visceral pain. This is when the organ itself is either inflamed or it's stretching, okay, and some sort of inflammation. So let's just say, for example, the stomach. Let's just say the stomach. Say, for example, a person goes through maybe some kind of stomach bug. Okay, they're going through gastritis, and the gastritis, inflammation of the stomach, causing the stomach to get inflamed and it's getting enlarged. This is what we call visceral pain. Visceral pain meaning the organ itself. Okay, so then what will happen here, there's symptoms. It will be diffuse, poorly localized, even though it is to that particular location, but they can have annoying, cramping, burning type feeling, okay, in that area. Somatic pain. This is when, say for example, this is when, say for example, a patient has an injury to the abdominal wall or somewhere around in the abdominal cavity, okay? And this type of pain can be sharp, intense pain. A perfect example is appendicitis. When a person has appendicitis, the appendix, you know where it's located, and it's the little thing here, and it pretty much hangs out in the abdominal cavity, okay? It just kind of sticks out there. So what happens is that when that gets inflamed, and especially if it was to burst, okay? Then this is now affecting the peritoneum, and then the patient has peritonitis. And so what happens now is that they have all of this inflammation here, and it can cause the issue. Now, when they have this appendicitis, it is very sharp, intense, and it is very well localized. And we'll go over appendicitis again, but when a patient has appendicitis, they'll know right there. It's right there, okay? That's a very good example of that. Referred pain. Referred pain, as you know, is something that's felt at one location. There's an issue at one location, and it's felt elsewhere, okay? Usually referred pain does follow a type of dermatome pattern. If you guys went over that in anatomy, do you remember that? Did you go over dermatomes? Okay, somebody saying yes, a couple of people saying no. Do you remember going over, you had to go over dermatomes. You went over nervous system, and so you know where your spinal nerves and where they supply. Well, keep in mind that those levels also follow dermatome, what they're called dermatome patterns. So say, for example, if a patient has an issue with, say, L4, L5, there is a dermatome on the lower extremity for L4, L5. And if you were to test that area, if the sensory is messed up, they're not going to have sensation. Okay, so that's how that follows. Now, with referred pain, very good example is a person that has kidney stones. Okay. When people have kidney stones, we all know the kidneys are retroperitoneal, they're back here, but we know that the ureters wrap around to the front, okay? So when they do have these kidney stones and it's passing through the ureter, it actually does follow the same dermatomal pattern as T12 through L2, okay? Which means that they'll have this sort of intense pain or sensation type along that area, going into the groin region. So, that's a very good example of referred pain. So we know it's coming from here, but then we know that it wraps around, okay, towards the front. Now, abdominal pain can be acute or it can be chronic. Usually when abdominal pain is chronic, this is usually from some sort of trauma. Maybe person had an ulcer, ruptured appendix, something like that. Then when we talk about chronic conditions, things such as Crohn's disease, diverticulitis, these things are more chronic, okay? They take a longer time to develop, and we'll go over those individually. Vomiting. So we have to talk about vomiting, gas, bloating. We have to talk about all that. Now, vomiting is the expulsion of gastric contents, okay? So whatever it is that you ate or whatever's in your stomach comes out. Please keep in mind that nausea is the feeling that you have to vomit. Now what happens, you can have nausea by itself, or nausea can be accompanied with vomiting. Okay? That's that. Okay. So the causes of vomiting, what happens with vomiting, I do want you to understand that this is a reverse peristalsis. Peristalsis, as you know, is when we eat food and it goes forward, okay? We know that it's like an ocean wave and it pushes the food forward. Reverse peristalsis is when it goes the opposite direction, okay? Now, peristalsis is very strong, okay? I usually tell the physiology students this example. You know the magician, I forgot his name, I think it's David Blaine, when he was hanging upside down for, I don't know, how many days when he was doing that magic trick. That hang upside down. Did anyone ever see that? You saw that? Yeah. How long? He was hanging upside down for like a couple of days or something in New York City. So anyway, when he was hanging upside down, he was still able to eat. And people were like, how is he eating? And so he was still able to eat because that's how strong peristalsis is. Okay? It's like a vacuum. It'll just suck the food down. Okay? So not to say you should eat upside down. Don't try that. Because you will still develop a sort of reflux from that. But you're still able to get the food moving in the direction it should. With vomiting, vomiting is such a, what happens when you vomit, it's almost like a I don't want to say rejection, but it's a, what's the word I'm looking for? It's something that when your body reacts to whatever it doesn't like, or it's a rejection that happens, okay? okay, where your body will now go into a state of reverse peristalsis. It doesn't normally do that, obviously, but when your body is in a disagreement with whatever the food is, or maybe there's some sort of issue where you could have a blockage somewhere, it will now do that as a compensatory situation to remove it. So that's reverse peristalsis, okay?
What happens when you let your vomit, you have to vomit, but nothing comes out? It's just, the reaction.
Oh, well, that's different. When it depends on what you ate or what's going on. So sometimes people vomit and they just vomit up acid. Sometimes people vomit, they vomit up nothing, or they vomit bile. So it all depends on what's going on with your body at that time. With people that are anorexic or that have eating disorders, when they vomit, sometimes they won't vomit up food. Like they'll continue to they'll vomit up the food that they want to vomit, but then they'll get to a point where they'll just vomit up nothing, and they won't vomit up anything, and then what the body is producing and what's left over is bile, because the bile isn't really getting out, and so they'll vomit up bile. So there are times where people can vomit and they won't vomit anything. So it all depends on what the situation is. Okay. Now, gas. Okay. What you should know about gas, intestinal gas. When you eat certain foods, okay, so say for example, we know that our bodies have enzymes that break down every food that we eat, such as our carbs, our proteins, and fats, and so we're good with that. Now, sometimes when your body lacks a certain amount of enzymes, okay, to break down that food, so say for example, very good example is lactose intolerant individuals, okay, they lack the enzyme lactase. Lactase is an enzyme that's supposed to break down that lactose. But what happens when they don't have lactase, that lactose sits there. And what do you think the body's going to do at that point with the lactose? It's just going to sit there, and so the body will try to break it down, and it breaks it down into a gaseous state. So it doesn't break down metabolically, it'll break down into a gaseous state. So hence the reason why you don't want to be around a person that's lactose intolerant when they haven't taken their little pill, okay, because that lactose will just sit and turn into a gas, okay, and that's exactly what happens in the intestines. So, lacking the enzymes and also motility. So when we talk about this gas and how gas is released, you already know how it's released, okay. Belching is the movement of that gas or an air or swallow. They say eruption of swallowed air, but it moves the gas through an air state. Causes motility disorder. Well, I shouldn't say it's a motility disorder. And keep in mind, a lot of things can cause belching. I'll tell you a story which is crazy. I have a girlfriend that has fibroids, really bad, and they're very large, and she has fibroids so much that it actually presses on her organs in her abdominal cavity, and it presses on her stomach and her esophagus and everything. This is just how large it is, okay? Or not the esophagus, but right at the top of the stomach. And she belches all the time, and it's because of that. It's not that she has gas, it's just because of the pressure is causing all that air to, and she's a teacher like me, and I don't know how her classroom goes. I just can't understand. Because I'm on the phone with her, she's like, oh, excuse me, she's always belching, and she can't control it. It's just sad. So until she get the fibroids fixed. So that can also cause, the point of me telling you that story is that sometimes pressure can also cause this issue too. So it's not so much just the amount of gas in the intestines. Okay, so along with belching, we already know swallow air. I already told you what happens with the enzymes. So what happens too is that bacterial and digestive action. So anytime, again, even if there is a certain amount of bacteria in the intestines, it can also cause a reaction and cause an extra gas production. So even when people do have certain bacterial infections in the intestines, whether it's gastritis, gastroenteritis, this can also give some sort of issues like that. And diffusion of blood. Okay. Abdominal distension, this is just another term for bloating. So when the gas or the amount of air, let's just say gaseous air, is to the point that it makes the stomach just stretch out or distend, this is what we're talking about. Okay. So that's that. Flatulence, we already know. Okay, what that is, and that is increased amount of gas. Okay, and it will come out. Now, constipation. Constipation, I want you to know, and jot this down, that this is decreased peristalsis. Constipation is decreased peristalsis. And what else happens with constipation that you think or may know of? What does it reabsorb?
Oh, fluids.
Or water. Very good, water. Okay, so keep in mind with constipation, this is decreased peristalsis, and also the body or the intestines will actually reabsorb more water, making the feces harder. Okay, so small, infrequent, difficult bowel movements because of the lack of water. Okay, this can be from diet, they say low fiber, exercise, and then there's also different pathological conditions that can cause this as well. Okay, now this, I'm not going to go into this, but I already told you, and we talked about how there's different enzymes that break down each and every food. Okay. Diarrhea. So what do you think diarrhea is going to be? Okay, so more water, we're going to have more excretion of water in the stool, and then we're also going to have increased peristalsis. Okay, so peristalsis will be increased with this.
It also causes change in blood, right? Is it alkalosis?
Alkalosis can cause it. Like if a person has metabolic alkalosis, it can cause them to have more of an increase in frequency with that. Now, what can cause this? Infection, and they also say stress. Now we're going to go over irritable bowel syndrome. In irritable bowel syndrome, they do directly affect it to stress. Okay, and people wonder, well, how does that happen? What happens is that when you talk about certain psychological disorders, it can actually trigger the parasympathetic sympathetic nervous system. And so when it triggers this sympathetic nervous system, it can get everything moving, okay, so to speak. So this is what happens with that. And actually, I have a anatomy and physiology book that I used to use at another school I used to teach at, and they had a whole chapter just on stress. And it was very interesting because it shows you how stress can directly affect your nervous system and how it directly affects your endocrine system. A lot of disorders, hypertension, irritable bowel disease, even some reproductive disorders are directly related to stress. But there's a component to that. It's usually a neural component why that happens. So it's very interesting. Now, some people can have chronic GI disorders. Okay, so this all depends on if people have food allergies or caffeine. Caffeine will do it. Okay, so those of you who are coffee drinkers, you know what it does. Okay, some people drink coffee just for that reason. Okay, because they know it actually will increase peristalsis. Okay, so that's that. Now, the pathophysiological mechanisms, slide 28 and 29, just cross that out for right now because we're going to go over each and every disease and we'll get all that information from there. Okay. Now, the first one we're going to go over, we're going to take these disorders from the mouth and go down. Okay, so starting in the mouth, the first one we have is stomatitis. Stomatitis is an inflammation in the oral mucosa. Causes here can be pathogenic organisms. It could be trauma, sometimes chemical irritation, chemotherapy. We talked about this already in cancer, so this is not our first time seeing this disease. And sometimes people that have nutritional deficiencies, okay, can start to have skin lesions or let's just say a breakdown in the mucosa. Acute herpetic stomatitis, this is from herpes simplex virus type 1. Type 1, not type 2. These are the cold sores. Now, people that do have this type 1, they do say that sometimes this is accompanied with a fever and sort of the whole, type of cold upper respiratory situation. But they can also have a tingling or prodromal feeling right at the site of where they're going to have a breakout. Okay, and those people that do suffer from this know. Sometimes this can be painful depending on how large the lesion is, and it can rupture if they're irritated. Okay. Type 1, keep in mind, cannot convert to type 2, but if a person has type 2, it can switch to type 1, or it can infect a person that's type 1. Okay, so just keep that in mind, because sometimes people, we all know what type 2 is, but the type 2 can exacerbate a type 1 situation. Okay. So treatment, making sure they use adequate oral hygiene. Medications, we know that there's antiviral meds. Keep in mind, and you already took micro, antiviral meds keeps the viral load down, not that it's a cure. Okay, so, and that's what they do for that. Okay, now, GERD. GERD, you guys already know. What is GERD? Reflux disease, so what happens? You tell me, what happens with the esophagus and what's going on?
Acid erodes away
Yes, the acid erodes away the lining of the esophagus, but then what makes that happen? What's the cause of this? Very good, the sphincter. It's the lower esophageal sphincter. Keep in mind that when you eat, you're eating, the food goes through the sphincter, opens, food goes through, it closes. Okay? And keep in mind, you only get a little trickle at a time. I'll explain that later on. But in any event, it doesn't close all the way. So when the sphincter stays open, once food is in your stomach, just to give you a visual, when the food churns, you have chyme and fluid and everything's just churning back and forth and all of this. So what happens, you have all of this fluid moving around in the stomach, but if the sphincter is still open, it's going to splash up into the esophagus. Okay, so that's the issue. That sphincter should be closed while the stomach is churning and getting the food digested. So this can cause a lot of issues. As you said, it erodes the lining, causing ulcerations. It can cause scarring, a whole bunch of stuff. Now, it can also cause something called Barretts Esophagus, which I'm going to go into detail in a little bit, because that is an extreme condition that can be out, as a result of this situation. Now, causes. All the different causes here, we know. Fatty foods, caffeine. Yes, caffeine can do it. Large amounts of alcohol. Smoking. Okay. Sleep position. Now, they have sleep position as a cause, but what happens if a person has GERD, and I think what happens if they're sitting up, is they're sitting up or lying down. There's a certain sleep position, I don't remember exactly which way it is. Maybe it's lying down flat. That it can cause more of an increase. Okay, especially as the food is digesting, it can splash.
It's on your side, because your stomach
It's on the side.
to one side. So
But it's on the side, laying down on the side.
And so if you lay on one side, it keeps the acid down, and if you lay on the other side, it has.
Oh, okay. All right. Thank you. That's what it is. So just laying flat on the side, but not sitting up.
Mm-hmm.
Okay. So laying flat on the side, making sure that that doesn't splash back up. But even if you lie on either side, if the sphincter is closed, it shouldn't be an issue, but it's an issue with it. So, all of this stuff we already know, but the main cause you should understand is that it is the lower esophageal sphincter that's not closing properly, okay? And all this other stuff is just an added situation to it. So not because you're smoking and you're eating fatty foods and drinking coffee, I don't want you to think you're going to get GERD that way, but it can increase it, especially if the lower esophageal sphincter is not working properly, okay? And then hiatal hernia. We're going to go into hiatal hernia in a little bit, so you'll know what happens with that. So, Barrett's esophagus, and I had a video, and I'm sorry to pull it up, but what happens with Barrett's esophagus, these individuals, we know that the acid splashes up into the esophagus, just keeps splashing and splashing. And so keep in mind that the esophagus has what is called normal squamous epithelium. So when it keeps splashing and splashing, it will change this epithelium to a columnar. This is what type of cellular adaptation? Very good. It's a metaplasia. Okay. Keep in mind, and I do want you to know this, that the cellular adaptation that happens with Barrett's esophagus is a metaplasia. When you have a metaplasia, what do you think that could lead to? Yes, it could lead to a dysplasia, which could lead to a cancer. Okay. So these patients are at risk for esophageal cancer. Please make sure you know this. This is a condition that could happen if a person has GERD. Now just keep in mind, this is if GERD goes untreated. Usually if people have GERD, they know and they feel it, and they go to the doctor and get it taken care of. But if a person just has this and ignores it, and it just keeps getting worse and worse, and all this acid just keeps getting into your esophagus, they can now lead to this type of condition. Okay? And again, it puts them at risk for esophageal cancer. Not to say that they're going to get it, but it puts them at a high risk because now the cells are changing over. Okay? So, that's important to know. Now, hiatal hernia, I really need to pull up this video to show you. Give me 1 second. Now, with hiatal hernia, let me just go back and then I'll show the video. With hiatal hernia, this is when, well, let me just ask you this first. Where is your hiatus? What is your hiatus? It's a break in the diaphragm, very good, and that's where the esophagus goes through and meets to the stomach, okay? That is the hiatus. What happens with that is that, keep in mind, this is your diaphragm, the hiatus is an opening. What will happen with hiatal hernia, these individuals will have sort of like a slippage of the diaphragm, and actually what happens, the hiatus actually opens up a little larger than it should. So when you have that hiatus opening a little larger than it should, what's going to happen is the esophagus and parts of the stomach can push up into that hole, okay? And obviously if it pushes up into that hole, what type of condition do you think the patient would have? If the stomach pushes up. It will cause GERD, very good. They're going to have definitely symptoms of GERD because the lower esophageal sphincter will be affected from that, okay? So, they say it increases with age, the older we get. And that makes sense because the older we get, everything just gets a little loosey-goosey. And so the diaphragm will actually just slip. They say women are more at risk for this than men. Okay, which also makes sense. So it can be life-threatening if a large portion of the stomach goes up. Okay, I've never seen that happen, but it can be. Signs and symptoms definitely similar to GERD, heartburn, chest pain, dysphasia. They get all of that. Okay. So we do have 3 different types. So let me show you the video because the video is really good with explaining these 3 different types.
screen to play, pause, rewind, or fast forward the animation. Your esophagus, the pipe that goes from your mouth to your stomach, passes into your stomach through a hole or hiatus in your diaphragm. Normally, the stomach is situated completely below the diaphragm, as shown here. The esophageal sphincter acts like a one-way valve to stop the acid that's produced in your stomach to break down food from flowing up into your esophagus. Here we show the valve opening and closing. In a sliding hiatus hernia, the sphincter and the top part of the stomach push upwards into the chest. A hiatus hernia can prevent the esophageal sphincter from closing properly. If this happens, acid from the stomach can pass into the esophagus and cause discomfort known as heartburn. However, often hiatus hernias don't cause any symptoms. Sliding hiatus hernias are usually quite small. They can slide back and forth through the hiatus, so symptoms can come and go. Sometimes sliding and rolling hiatus hernias are present at the same time. This is known as a mixed hernia. This is the end of the animation. Click on the animation screen to watch it again.
Okay, now, let me just explain to you really quickly the three different types. The sliding hiatus hernia that she showed you in the video is the most common type, which means that you'll have the portion of the stomach that's right next to the esophagus. That's the portion that pushes up into the hiatus. But then when you have the rolling, this is the one that's the greater curvature of the stomach, and it rolls up. So this is the one that looked more like a big bubble sitting on top. This is the one that comes out and sticks out even more. Okay. Now, sometimes individuals can have a mixed, okay, where you have the sliding and rolling together. So it's a very large portion. So the larger the portion of the stomach that slips up into the hiatus, this is definitely going to be a lot of issue. Okay. And just by looking at that, that looks like that person would have a lot of heartburn. Okay, so that's the hiatal hernia. And they do have pictures here to show you. Now, the next condition here is something called Valerie-White syndrome. And this one is not so involved, but basically what happens here is that these individuals get a tearing in the esophagus, in the wall of the esophagus, and this comes from forceful vomiting. Okay, so let's say patients that may be bulimic, okay, could have this situation. What else? Any type of forceful vomiting. So even say, for example, if someone had some sort of intestinal infection, okay, so if they had food poisoning, you know what happens with that. Okay, so any type of excessive or forceful vomiting, okay, can give this situation. Now, signs and symptoms of this, which is not listed, so I do need you to jot this down. It is vomiting of blood, which we know. Epigastric and back pain also goes along with this, okay, because you know, if you've ever had an experience of vomiting, and if you vomit too much, you know what that feels like, okay, you do have a lot of back pain and stomach pain. Now, what will happen here, they do have other factors that can contribute to this. So ingestion of alcohol, okay, can also cause this forceful vomiting. We all know if you have a night of drinking too much, okay, what that can do. Okay, so if it's too much, and especially with alcohol, because of the substance of alcohol, can cause a lot of irritation. Coughing. Believe it or not, some people that do have chronic coughs or either go through, say, a bronchitis or respiratory condition, and they're coughing a lot, they can also have this type of pain too. Pain and also this sort of vomiting. Trauma, hiatal hernia, esophagitis, and gastritis, okay, or other things that can contribute. Now, esophageal varices, not much to say about this, but this is a major issue because it does have a high mortality rate. But what happens with esophageal varices is that these individuals do have what is called portal hypertension. okay? So in their portal circulation, it will go through hypertension, and this is usually from people that are alcoholics, okay, most of the time. And so when they have this portal hypertension, it will cause the veins and the vessels to just dilate. And you know what happens when things dilate. When they dilate, remember the blood just gets stagnant. It's not moving as it should. So this is definitely an issue where these individuals will have an issue with circulation. Now the next two things we have is gastritis and gastroenteritis. Are you guys okay, or you need a break? You need a break? No? Okay. Just want to make sure. Now, gastritis. Gastritis, very fancy term for just inflammation of the stomach. That's it. Okay, so what can inflame your stomach? Two main things that can inflame your stomach are the two things that actually get absorbed in your stomach, which is alcohol and aspirin. If you remember from anatomy or maybe physiology, alcohol and aspirin are the only two things that get absorbed through the stomach, through the GI wall in the stomach. So, if a person has this irritation, so say alcohol and aspirin, and as you know, you never want to mix that, okay, together, because it will obviously cause more irritation. Not only that, just building up a bunch of acid. So what happens here is that if you constantly have this crossing over of these substances, it will cause the irritation to the lining. Now, what other thing do you think it will cause? Something that you may know. What is it?
Ulcer.
Ulcers, very good. So it could cause an ulcer. The more you have this inflammation of alcohol, aspirin wearing away that lining, it can wear it away and cause an ulcer, okay, and just break it down. So, and we'll go into that in a second. So, signs and symptoms, they do say nausea, anorexia. Hematemesis is vomiting of blood, okay. And postprandial discomfort, meaning after they eat, okay, it's not comfortable. Okay, they do have pain. Now, gastritis, when it's chronic, they do say the main cause of gastritis is what is called H. pylori. Please make sure you highlight this because I've seen this in several NCLEX books. You do have gastritis, I even think gastric carcinoma, and even peptic ulcer. They do believe all three of those are caused by H. pylori. Okay, so this type of bacteria they believe is the cause for these diseases. So that's that. Now, gastroenteritis, what is this? This is the same thing, but just now we're involving the intestines now. Okay. Now, with this is usually a result of some sort of direct infection. Maybe this is what they normally call the stomach flu. Okay, gastroenteritis. So there's usually some sort of pathogen or viral component that gets inside the intestinal wall and causes this inflammation. And you guys probably know the signs and symptoms already of this. Okay, so do you know the signs and symptoms? Diarrhea, if you know, sometimes vomiting, nausea, fever, malaise. Okay, and if you ever had the stomach flu, you know what it feels like. Okay. So treatment is just to replace the fluid and electrolytes because again, most of the times these things are viral. It'll run its course, it'll stop. Just make sure that you replenish with fluids. Peptic ulcer disease. Causes, again, H. pylori, hint, hint, please highlight that. H. pylori, we see this again. They say stress can do it, spicy food, alcohol, smoking, okay, and they say sometimes this is genetic, okay. Now, a lot of these things we all do, okay, we all get stressed out. I like spicy food, some people like that. So, it's these things that we normally eat, and then according also to our lifestyle. So this is another thing that's important to ask your patients questions, especially during an intake. What's going on with them? Did they just get a divorce? Did they increase, how many cigarettes they're smoking a day? Are they going to the bar every night, because of the divorce? So, these things can start to cause certain issues that you wouldn't think about that have to deal with that. So, here we go. With these ulcers, I have another video. With these ulcers, what happens, as you know, the GI wall has 4 layers. You have your mucosa, submucosa, muscularis, and the serosa layer. When a person has a true ulcer, it will go through 3 layers. So it'll go through the mucosa, submucosa, and extend into the muscularis layer, and that's pretty deep. But then sometimes people can have a penetrating ulcer where it'll go all the way down to the serosa layer, which means it's almost like having a straight hole right through the organ. Okay, so what happens here? With an ulcer, especially a gastric ulcer, what makes the stomach able to handle so much acid is that there is an alkaline layer, okay, in the stomach. And it makes sense, okay? I did something really crazy like a couple of weeks ago. And don't laugh at me when I tell you this story. You know Advil and how they have the gel caps? Well, I made a mistake and I bit it for whatever reason. When I tell you my mouth burned, it burned for like 15 minutes. Those things are extremely acidic, and it just burned. I'm like, oh my gosh, like how? And I was thinking, how is my stomach able to handle that? Because it really burned my mouth. But what happens is that the stomach has an alkaline layer, so it can withstand extreme acidity. So what happens with this situation with the ulcer, what'll happen is it'll burn that alkaline layer away, and now the acid will just start to erode the rest of the epithelium. And not only that, it will actually produce more acid if you burn the alkaline layer away. So this is a situation there. Yeah, I have a better picture to show you. Okay, so with duodenal ulcers, they do have excess acid that's being produced, okay, in the intestines, and this can cause the same issue here. Okay. And I'll show you a better picture, don't worry. Now, before I get into treatment, let me give you signs and symptoms because it's not listed in the PowerPoint. So the signs and symptoms of a peptic ulcer will be epigastric burning pain. So if you want to jot down, epigastric burning pain. And this is usually relieved by food. It's usually relieved by food, especially dairy or antacids. It's usually relieved by food, especially dairy or antacids. Sometimes these patients have pain on an empty stomach. And the other signs and symptoms they could have nausea, chest pain, and a late finding of GI bleeding. So I just want to show you an endoscopy of this individual that has 2 large ulcers. So there's one, okay, and as you can see the lining is just completely gone. And then this other one here that's wider. It looks wider, not only that, it looks deeper. Okay, so that's what it looks like. I figured this video is better than what they're showing you in the book. Huh. So, yes, they have some nasty little pictures here. I don't even know what those are. Okay. So treatment here is going to be antibiotics because, again, they do feel that it's the H. pylori that causes this. Okay, so please make sure you understand that. That's what they believe is the cause. H2 antagonists and proton pump inhibitors. What do you think they're going to do?
Reduce acid.
Very good. They're going to reduce the acid because they're taking out those protons. Okay, They're going to relieve those protons, release those hydrogen ions, and get them out the way. Sucralfate, this will definitely help protect the coating or the lining of the mucosa. Tell them to stop smoking, stop taking the aspirin, and all of that spicy food and things that are irritating, and manage it that way. Okay, so this is the treatment. Okay. That picture just showing you how the little H. pylori gets in, and they think that that's the issue. Yes?
How would you handle a patient that is taking aspirin prophylactically for
Oh, well, what'll happen is they say that the baby aspirin, it shouldn't cause it so much, but yes, over time. So unfortunately, what they do is they make sure they take the aspirin because they feel that that's more important, and then they'll tell them to also take something for this. So they will also follow up with some sort of antacid type of medication. So whether they give them a H2 antagonist or whatever. And so this is what keeps you guys busy, because patients will have side effects from one medication and they have to take another medication for the side effect. And so that's a very good example of that. They will take another medication to handle the ulcer situation or to prevent the ulcer, but they have to continue taking that aspirin because they look at the circulation as being more important. Okay. So that's that. Now, ulcerative colitis. Ulcerative colitis, just to let you know, this is a chronic inflammatory disease. Okay, so this is not an acute situation. These individuals do have large ulcers, okay, and this is localized to the colon and the rectum. Please make sure you know the location. Now, what happens here is that these ulcers that get so far down, they say, especially in this area, that this can put these individuals at risk for colon cancer. Okay, so, and we know that colon cancer is usually localized to that area. Okay. Now, the hallmark here is that they will have bloody diarrhea, okay, and abdominal pain. I would highlight that. Please make sure you know that. I've actually seen that in one of the NCLEX books as a question, okay, that this is a hallmark of bloody diarrhea. Also with these patients, I do want you to know, they can have exacerbations and remissions. So because this is a chronic condition, they can just one day, oh, feel fine, and then the next day, it's another problem, okay? So they can go into exacerbations and remissions. Now, the way they treat this, corticosteroids, and they will give them salicylate analogs, which are pretty much like, I think it's the same component that's in the medication Imodium to decrease diarrhea. So it actually decreases peristalsis, okay? So they'll just pretty much give them medication pretty much to treat the symptoms, pretty much, okay? So it's not a direct cause. Now, this is not a good picture, but what they're trying to show you is that the ulcers, when it gets down into the colon area, they're more of a, it looks more like an irritation or bleeding, more bleeding ulcers. Crohn's disease. Crohn's disease is something that I think is quite common, a little more common than we want it to be. What happens with Crohn's disease, this is another chronic inflammation or irritation that happens. It is to the proximal portion of the colon and the terminal ileum. What you should know is that this inflammation goes through all 4 layers of the GI wall. Okay, so this is definitely a chronic situation, all 4 layers. So, they do say that, okay, well, what is the Crohn's disease? What is the cause? They say there's no known etiology. So what happens here is that these individuals, they believe, may be allergic to something or something irritates that causes this situation, this whole inflammatory process. My niece had Crohn's disease, and I remember in the beginning stages when she was going through treatment and figuring out, they did a lot of food elimination with her because they thought, okay, well, maybe certain foods were causing irritation. And so they will do that with these patients because sometimes they will eat something and they don't know what triggers it off. And so it's something that triggers off this inflammatory situation. But again, in each patient is different, so there's really no known food. We can't say, okay, well, eggs will do it, or dairy, what have you. But it's something that'll cause or set this off. So what they're trying to show you here in this picture, and I know it looks kind of fuzzy, but you see like these white patches. In those white patches, they're trying to show you the areas of inflammation and how it actually goes all the way through. So it'll go through to the point that it'll almost break the mucosa layer. Okay. Now, signs and symptoms: intermittent bouts of fever, diarrhea, right lower quadrant pain, which is similar to the area where people have appendicitis. Okay, so not that this patient is having an appendicitis, but it's just because of that region of the terminal ileum. And they may have a mass there. Treatment, they say to stop smoking. And of course, smoking, they contributed to everything almost. And another thing here is that, which they're not putting in here, is to looking at the foods. Okay, you have to look at the foods and see what it is that they're eating, because it may just be one thing that's causing this irritation, and so to eliminate that. And also stress. In your book, they talk about Crohn's disease is actually so debilitating sometimes that these patients even have support groups, because they can be, say, sitting here in class and you have to get up, run to the bathroom, you don't know what's wrong, and you get very ill just out of the blue. Okay, so that's that. Oh, another treatment for Crohn's disease, I forgot to say, they did this with my niece. They can do surgery on these patients. So because they know the location of where the inflammation is, they can go in and take out that area of the intestines. And she had that done, and that actually was her cure. Okay, and she was fine with that. Okay. So enterocolitis. Enterocolitis. Now, under enterocolitis, we do have a couple of different ones here. And the first one we have is antibiotic-associated colitis. What is this? This is when a person has an inflammatory process in the intestines from taking too much antibiotics and now developing a C. diff. Okay? And this happened to my mom because she's the antibiotic queen. That's all she does is take antibiotics. And I tell her that stop taking those antibiotics, is not, because she suffers from really bad sinus infections and she always has something going on. And so every time you go to the doctor, they're just giving scripts of antibiotics. And so this can be, unfortunately, an outcome. Patients get very ill. She became very ill, vomiting, diarrhea, vomiting all over the place, and went to the ER. They treated her, found out it was a C. diff, and so the way they treated her, definitely the first thing is giving the patients fluids, okay, because everything's just gone by that time, especially if it's, and when we're talking about vomiting, we're talking about almost like a food poisoning type vomiting. Okay, so the body really, really reacts to this. And they do have another type of stop the current antibiotics, and then there's another type of antibiotic just to handle the C. diff. Okay, and so that's how they treat that. So it is quite common. Now, something called necrotizing enterocolitis. Okay, this can happen in infants. Okay. So what happens with these infants, they will go through some sort of inflammatory process in the intestines where the intestines will start to get necrotic. When those intestines start to get necrotic, unfortunately, that baby is going to get septic, okay, because especially in that area. Now, the only way to treat this is to take it out. Once you have an area of your organ that's necrotic, you can't let that organ stay there and think it's going to get healthy again. You have to remove that area once it becomes necrotic. Okay. So surgery, they give them antibiotics just to make sure, any type of microbial bacterial infection, and that's that. Appendicitis, we already know. We talked about this a little bit before. Appendicitis, we know where the appendix is located. Sometimes, if you have experienced this or know someone, it gets inflamed for whatever reason. Sometimes they say maybe fecal matter could get lodged in there, causing this inflammation. And we know when it gets inflamed, this causes a lot of pain. Okay. McBurney's point, you know where that's located. They do have all the signs and symptoms like a viral infection, the nausea, fever, vomiting, all that. When you guys do your physical assessment, there is a type of test that's done, I believe it's called rebound tenderness, where you take your hand like this and you just go right into the abdominal, right at McBurney's point. And when you remove it, hopefully your patient won't kick you. But basically you're looking to elicit that pain, okay? So you're looking to elicit that pain that is going on in that region. So what they do, take it out and it's fine. Okay, so take the appendix out. Now, let me just say this. If someone has appendicitis and it's just an inflammation, they take it out, okay. But then once a patient has an appendicitis and that appendix bursts or it ruptures, keep in mind that whatever the contents that was in there will now spread through the peritoneum, and then these patients can have peritonitis. Okay, so now they have an inflammation of the peritoneum. If the peritoneum or peritonitis gets really, really inflamed, what is the next thing that you think might happen? Very good, sepsis, okay? Because this patient now will have a systemic inflammation because now it's gone here and it's spreading, okay? So once we're in the peritoneum, it's spreading to other cavities, so they will now become septic, okay? So just make sure you understand how that flows. Okay. Oh, it's 11:20. Okay. Do you need a? I don't know if I want to do a break or just stop it. Do you need a break? Let me keep going, and I'm gonna stop soon. Okay. Yeah, let me do that. There's a few things I'm probably going to have to hold out to next week, but it's okay. We'll be able to get in it. Okay. So, diverticulum. We talked about this already a little bit. So we know what a diverticulum is. This is an outpouching that happens in the GI wall. Now, the one thing I want you to know about this, there's two different types. We have a diverticulosis and a diverticulitis. A diverticulosis, I kind of call it like a functional diverticulum, which means that these patients will be asymptomatic. So they'll have this diverticulum, maybe food's getting trapped there, maybe not, but they're functioning and it's not an issue. Then you have the diverticulitis where it becomes inflamed. So that diverticulum will become inflamed, whether from food being trapped there or whatever's going on. And then they'll have fever, abdominal pain, and all bunch of symptoms. Now, treatment is antibiotics because yes, can this lead to a bacterial infection because all that trapping of food? Yes, it could, okay? Or surgery, okay? So this is kind of what it looks like. Now keep in mind, and you guys probably know this already from management, there are certain diseases and conditions that a patient may have that could warrant them to need antibiotics. Not that they have a bacterial infection right now, but because of the situation, it could lead them into a bacterial infection, so you want to kind of pre-treat that situation. So, that's that. Now, irritable bowel syndrome, this is when the people have this over 3 months, okay? Let's say over 3 months. So this is chronic. This is a chronic condition. So when we talk about what's going on over 3 months, we're talking about consistent diarrhea, sometimes constipation, so it can go back and forth sometimes, constipation and or diarrhea. So they will have something else written down. Okay. Flatulence, they say the cause unclear, but it is slow wave of bowel slow wave activity of the bowel. Often associated with anxiety and depression. So as I explained to you that when patients do have or people suffer from anxiety, depression, stress-related disorders, it will directly affect the parasympathetic and sympathetic nervous system. When those sympathetic and parasympathetic nervous systems get triggered, that will directly affect your heart rate, your peristaltic rate, activity in your GI tract. So it will affect a number of things. Okay, as you know, what happens when you get anxious, your heart increases and all that. Same thing here. Now, signs and symptoms, diarrhea or constipation. Okay, so they can have it and they can alternate with it. Cramping, mucus in the stool, nausea, bloating. How to treat this? They treat the symptoms, they give them anti-diarrheal meds, decrease the spasm, and tell them to get some fiber in their diet to get everything going back to normal, okay? And calm down, okay? Now, I'm getting tired. Let me do intestinal obstruction. There's two types, and then I'm going to stop with that. So with intestinal obstruction, you tell me, what do you think some things that can get trapped in the intestines? What do you think can get trapped in the intestines that could cause obstruction in the intestines? A mass, very good. So like a mass or tumor. What else? Feces, very good. So if feces is not moving properly, okay, to where it needs to go, it can just get stuck and stay there. There are a lot of different things that can happen. Tumors, adhesions, hernias sometimes. We will go over what is called volvulus and intussusception in detail because those are two, major, they're complicated situations. Sometimes people can have a functional obstruction if for some reason they have some sort of neurological issue. So whether it's from a spinal cord injury, sometimes drugs can do this. So people that do have drug overdose, people that have a drug overdose, they can have a whole bunch of problems, okay? Because as you know, the nervous system, it will directly attack the nervous system. And when you attack the nervous system controls everything, okay? So as you know, they can have a whole bunch of situations. Now, signs and symptoms here, depending on the site. But one thing that you should know is that if you have an obstruction, keep in mind that these individuals are not having proper digestion, which means that they will be dehydrated and they will be depleted of fluids and electrolytes. Okay, so that is something that definitely should be also treated. Constipation, abdominal distension. Most of the times, depending on the severity of the compression or obstruction, they have to have surgery. Okay, so they have to remove whatever is obstructing. You can't let it stay there. There's nothing really that can push it out or move it through. It has to be removed. Now, the first one we're going to talk about here is something called volvulus. Now, the best way I can explain volvulus, this is an obstruction that happens inside the intestinal wall. So say, for example, you have a child, and we know children put things in their mouth, okay? So say, for example, a child swallows one of those little car toys, okay? So they swallow the car toy, it's going down, and then the body's trying to digest it because it doesn't know it's a car toy, it just think it's food. So when the body's trying to digest this, keep in mind that the GI tract is like this, and it's going into a state of segmentation and peristalsis and trying to move and push it through. Now, as it's trying to move and push it through, you have this car toy, this toy that's stuck there, and it's not breaking down because we don't have an enzyme to break down Hot Wheels, okay? So, it's not breaking down. So what will happen is now the intestinal wall will, or actually the tube will start to turn on itself because it's moving and moving and moving, trying to break down, and that's what the body's supposed to be doing. But because this toy is not moving the way it should or breaking down, now the valve will actually twist on itself, okay? So you understand how that happens. So it'll twist because of the whole peristaltic or segmentation activity. So it will rotate. Now, common sites are the cecum and the sigmoid colon. Why? Why do you think that's a common site? Those are the areas that curve. The cecum curves, it's like a little pouch, as you know, and then the sigmoid colon also curves. So it's an easy target for things that get stuck there. And if it gets stuck, and keep in mind it's still trying to go through its whole peristaltic thing, and it will start twisting on itself. So this is what it'll look like, though, before I get to that. So when it starts twisting, what you should understand is that just imagine if you just take something and twist it. Now we're blocking blood flow. to that area. So now it will get necrotic and possibly get gangrene, okay? And that's an issue. Life-threatening, definitely, and these individuals are dehydrated, vomiting, and all that stuff, okay? Now, here we go. This can happen to the bowel, okay? It can twist just like that. So, say for example, again, we were talking about the child that swallowed the little car toy, and it's stuck there, and now this has caused this sort of twisting motion. As you can see, they're trying to show you here that this area is white, and even all of this, because now we're stopping circulation. So now all of this area is now lacking blood flow, and it now can get into a state of necrosis. Okay, so keep in mind that this, once we have a tissue that gets necrotic, this has to be taken out, especially if it gets to the point where they get gangrene. Okay, and this has to be removed, surgically removed. Okay. Now into succumption. This is pretty much the same type of situation. So someone's ingesting something, just using that as an example. But this can be anything. Keep in mind that this can be a person that has a tumor. Okay, so maybe they have an intestinal cyst. Okay, and because that intestinal cyst is in the way, when the food's trying to pass through, it can now cause this sort of disruption and causing this issue. So the problem here with intussusception is that you have the GI tube, and the tube will sort of do this sort of invagination on itself. So as it's trying to move and move through, it will just kind of do a folding, okay, and that's what will happen. So obviously if you do more of a folding, now we really don't have much, I shouldn't say airway, but much of a, opening. So males more than females for whatever reason here, I don't know. Signs and symptoms: increased bowel sounds, okay, abdominal pain. And again, the way to treat this, they have to remove this. They have to take it out. So this is what it looks like. They also call this telescoping. It's a telescoping of the bowel. Okay, and that actually, I can imagine that also causing abdominal pain as well. Okay. Hirschsprung's disease, you can cross this out because they don't really talk much about Hirschsprung's. The only thing with that is they say this is a congenital disorder that it's a congenital disorder that actually causes the intestines to be, or to decrease the motility, it decreases the motility of the intestines. This is a congenital disorder that decreases the motility of the intestines. Because they don't have autonomic ganglion, which helps with the motility. So, signs and symptoms: diarrhea, hypovolemic shock, okay, and then they have to take it out. All right. Okay, I'm gonna stop here. Is that okay? Okay. I'm tired, you're tired. All right. So I'm stopping. Let me just say this for everybody in the video, people that's going to see the video. I'm stopping at slide 74. Okay, so for the test, okay, and for next week's test, or the test that I'm going to send you, keep in mind, the test I will be sending you an email and just letting you know, okay, that you can take the test on eCollege, okay? And keep in mind, when you start the test at home, because it is a take-home test, but when you start it at home, once you start it, it starts the timer, okay? So you only have a certain time to take it. So I don't want you to think that it'll be open for all night for you to take it, okay? So it is a timed exam. Now you can start it whenever you want. You don't have to hurry to do it.
Whenever you're taking this.
I'm gonna send you an email, let you know when it's ready. Okay. I'm gonna send it. I'll probably send it either this weekend or Monday, so you'll have time to take it. So it's not like a rush where it has to be done like immediately. But the point I'm trying to make is when you do open the test, once you open it and you click begin, it has a timer. So it's gonna time you. So I don't want you to think, okay, you got all night to go through it and open the book and do all this stuff. it will shut it off at a certain time. Okay, so I'll give it probably like that hour or whatever. Okay, and keep in mind, I'm doing this just to keep consistency because I wasn't with the other two sections, okay? And what happens, people talk and they, oh, well, if she's doing this for one section and the other section, you know, so I just want to make sure we're all happy, okay? So, any questions? Okay, and you will also get the video. The video is being recorded, as you know, for sections 1 and 2, but I will also send the video to you guys as well. Okay, so you can have the lecture and you can look at it again. Okay. So what we'll do now is I'm dismissing you, but I know some people came in late and some people still have to take the exam. And if there's anything you need to work out with me or you need to go over anything, we'll spend that time to do that now. Okay. Yeah.